I'm Dr. Mary Ed Davis, and I'm one of the nurse consultants here at the Alabama Board of Nursing. My area of responsibility is the Voluntary Disciplinary Alternative Program. At the conclusion of the presentation, you should be able to discuss the epidemiology of substance use disorder and the physiologic changes that occur, identify risk factors that are specific for nurses and which ones are present in your facility, identify reasons nurses are reluctant to report substance use disorder in themselves or others. You should be able to recognize some behaviors that may indicate a substance use disorder in a coworker or an employee. Discuss strategies that can be used in your workplace to detect and deter diversion and to identify the role of the Board of Nursing for nurses with substance use disorder. You should be able to locate the administrative rules that govern discipline, probation monitoring, and VDAP on the board's website, and identify the differences in VDAP and probation monitoring, and to understand some of the rationale for the employment restrictions in agreements and orders for monitoring. It is estimated that somewhere between 8 and 20% of nurses nationwide may have some kind of substance use disorder. It is difficult to get accurate numbers because different studies have different numbers, so I just combined the studies that I looked at and came up with 8 to 20%. The incidence in nurses is probably about the same as what it is for the general public. Males do constitute an overrepresentation of nurses. Males are only 5 to 9% of the total percentage of nurses, whereas there's 16 to 19% males that are represented in the substance use disorder population. A history of co-occurring disorders is common, and a significant percentage of female nurses report a history of physical and/or sexual abuse. Is addiction a disease? The jury is kind of in on this one in the scientific community. Substance use disorder is defined as an illness. It has specific signs and symptoms and a predictable course if left untreated. Where the picture gets muddied somewhat is that many of the behaviors associated with substance use disorder deviate from acceptable societal norms. Historically, mental illness and substance use disorder have been criminalized and thought of as deviant, even evil behaviors, and thus there are a lot of religious overtones seen in some of this too. The understanding of substance use disorder as an illness has been relatively recent, and not all healthcare professionals or the public buy into this. The definition of addiction that is on this slide comes from a publication called Drugs, Brains, and Behavior, published by the National Institute on Drug Abuse. And they define it as a chronic relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences. It is considered a brain disease because drugs change the brain. They change its structure and how it works. These brain changes can be long-lasting and can lead to the harmful behaviors seen in people who abuse drugs. The first stages of addiction, there are disruption of dopaminergic pathways. Brain pathways are constructed to ensure that we repeat life-sustaining activities by associating them with pleasure or reward. When the reward circuit is activated, the brain notes that something important has happened and remembers it. We are taught to do this again and again without thinking about it. The dopamine system in brain circuits regulates movement, emotion, cognition, motivation, feelings of pleasure. The drugs may mimic a neurotransmitter or fool one of the receptors to allow the drug to bind with that receptor or to cause nerve cells to release abnormally large amounts of the transmitters. This leads to abnormal messages transmitted in the brain. An overstimulation of the dopamine system leads to feelings of euphoria. Some drugs of abuse cause somewhere between 2 and 10 times the amount of dopamine to be released, much more than a natural reward would. And if the drugs are smoked or injected, this may happen almost instantaneously. In the second stage, the person may very well develop a withdrawal syndrome if they do not take the drugs. There is a vulnerability to relapse. There's alterations in judgments and decision making. There are alterations in glutamate pathways, and these pathways are associated with judgment. These processes are needed for successful abstinence. The third point is very important. If someone is in active addiction, they most likely are unable to abstain from drug use. Just say no is a great strategy for dealing with peer pressure, but it is not a useful strategy for those who are in active addiction. This slide shows a simplified representation of the epidemiology triad. You will see, you all have probably seen this with other diseases, infectious diseases, etc., but the CDC uses this for almost any disease or process that they monitor. What this shows is that substance use disorder is a multifactorial disease, and it depends on the interaction of many elements for substance use disorder to occur. First, we'll consider the risk factors of the host, and all of these risk factors are common to anyone who has a substance use disorder. These are not specific to nursing. The biology and the genes of the host. Genetics accounts for about 40 to 60% of a person's vulnerability to addiction. There may be significant family history of alcohol or drug addiction, but keep in mind that if someone has genetic markers or a significant family history, that does not mean they will develop a substance use disorder. It simply means that the proclivities are there, and if the right circumstances occur, they may develop one. A risk factor is being of the male gender. Also, co-occurring disorders, particularly depression, mood disorders, and ADHD, and a few others, are fairly common among those who have substance use disorder. Also, the use of drugs or alcohol prior to age 15 is associated with significant substance use disorder. The agent is the drug itself. Some drugs are simply more addictive than others. Cocaine is one of the most addictive substances around. So is nicotine, so is methamphetamine. There are many things that are very, very addicting. Xanax is more addicting than Ativan because it has a shorter onset of action. Those drugs that have short onsets of actions typically are more addicting than their longer acting counterparts. Also, the route that it is administered is important. Drugs that are taken IV or inhaled or snorted or smoked are much more addicting. One of the issues for nursing is availability. If the nurses divert from work, the drugs are there. They are definitely available. Cost is also a factor. A lot of people cannot afford powder cocaine because it is very expensive, but they can go and get crack because it's much cheaper. Then we look at risk factors in the environment. A dysfunctional family of origin is a huge risk factor. Many people with substance use disorder have dysfunctional patterns in their families. They may have enmeshment with parents or children. There may be domestic violence, constant chaos. There may be very inconsistent discipline with children. There's just all kinds of things that go on. Many people with substance use disorder have never experienced normal relationships between parents and children or between men and women or adults and partners. They've never seen normal relationships, so they have no frame of reference on how to choose these kinds of relationships or how to raise children. Nurses seem to have a remarkable propensity to choose bad partners and for continuing to choose the same kinds of partners. I don't really know why that is, but that's the case. There is a very significant amount of abuse that is associated with people who end up with substance use disorders. Also, involvement with the criminal justice system. You may see multiple arrests for misdemeanor type things like malicious mischief, domestic violence third, harassing communications, bad checks, public intoxication, that sort of thing. In many families, particularly with nurses, the nurse sometimes is the one that has the benefits for the family. The other partner in the relationship may work, but it may be episodic work. It may not carry benefits, may not pay as much as nursing. So there's a lot of pressure on the nurse to continue to work, even with lots of problems at home. Now we will discuss some risk factors that are specific to nursing. There are 4 basic categories of these, and we will discuss these in much greater detail. These are the risk factors that nurse executives and supervisors and administration of facilities can exercise some influence. The first risk factor specific to nurses is access and availability. Controlled substances are everywhere in the places that nurses work. Nurses have to develop a certain amount of comfort with handling these substances because they have to give them. And so sometimes what happens is the ubiquitous presence means that they become sort of blasé about it and they don't take it very seriously or as seriously as they should. They also have a lot of knowledge about and use of controlled substances. They give these medications to their patients all the time, and they have to know a fair amount about it. There are also lax administrative procedures for the accountability of controlled substances. There may be variations in the application of your policies about controlled substances from one unit to another. And then there are prescribing practices of physicians. Many physicians are known as free prescribers of pain medication. Nurses know who these physicians are, and they will go to them. The next factor taken into consideration is occupational stress. Work schedules are a big source of stress for nurses. 12-hour shifts are the norm, particularly in acute care. Nurses will say they weren't given any other options for working, and administrators will say that nurses demand this because they like having the other time off. This is not particularly responsive to workload or to the needs of all your staff. 12-hour shifts require probably almost half of your nurses to work hours that are at odds with a normal sleep-wake schedule. 12-hour shifts, the nurses report increased fatigue, there are interruptions of their body rhythms, and as the shift increases in length, there's an increased chance of errors, and as they become more and more sleep deprived working these shifts, they may try some kind of sleep aid. For some nurses, this is the first step on the path to a substance use disorder when they're trying to go to sleep at 8 o'clock in the morning instead of 10 o'clock at night. And when someone switches from day to night, their sleep deprivation increases, and it's just not a great schedule for a lot of people. Drowsy driving is increased after shifts, and This is truly a quality and safety issue for nursing. There are studies that show that the greatest frequency of errors occurs during hour 9 of a 12-hour shift. And the more extended shifts nurses work, the more sleep deprived they get. Then there is the nature of the work itself. Nursing itself is stressful. You're dealing with people who are not at their best. You may be dealing with families, with other departments, lots of people. And while nursing is certainly rewarding, it is a difficult, physically and emotionally demanding profession. If people don't have the ability to get away from it every now and then, they're going to get more and more stressed and burned out. Staffing issues are ever present. Chronic staffing problems lend themselves to shortcuts in work. Now, some shortcuts are acceptable, but many nurses are not very good at deciding which shortcuts are acceptable. There may even be some shortcuts that are not really lawful. And a lot of nurses just don't have a sense about this. There's also the hostile workplaces, vertical and horizontal violence and abuse. They may be abused by physicians, co-workers, administration. A common complaint from nurses is that they do not feel supported by their administration. There may be administrative policies that do not support people reporting themselves or other nurses who have issues with substances. The atmosphere that is out there is generally one where those who come forward with a substance problem are punished. A lot of times they will avoid reporting themselves until the problem has gotten way out of hand. There may be little meaningful employee assistance. There may be some, but it may not be very good. And there's little mental health or substance use coverage in many health plans. Now, the Mental Health Parity and Addiction Act of 2008 guaranteed parity for mental health problems, etc., with other kinds of disorders. Unfortunately, many large insurance plans were allowed to opt out of this because they were able to show how their projected financial costs were too great to implement. So there are still many insurance programs that have very poor benefits for mental health and substance use disorder. Then there's the lack of knowledge about substance use disorders. In general, nurses and other administrators don't necessarily know that much about substance use disorder. They don't know that much about it in nurses, and they don't know or understand the monitoring and regulatory requirements for all levels of nursing practice. Many nurses have had very little information given to them when they were in nursing school about substance use disorder, and this lack of education about it continues throughout their careers. The lack of knowledge also fosters continuation of stereotypes and mistreatment. Part of the problem is that there's lots of information being given to people out there about substance use disorder, but a lot of it is wrong. And when you are perpetuating information that is incorrect, then the stereotyping continues. This makes part of the atmosphere where nurses don't want to come forward for help. Then there are the attitudes that nurses have. And these are kind of unique. One is that drugs and alcohol are socially acceptable ways of coping with life stresses. You may see sharing of medications because, well, we're nurses. We know all this. It's okay if I take your Xanax or whatever. Boy, we've had a bad day. Let's go to a bar and have a drink, etc. That's present throughout our society. Also, nurses see medications as a way to alleviate suffering. And because of their comfort level with controlled substances, they have the idea that if they take something, then they'll be able to tell if they're getting into trouble and getting addicted. And this is not true. There is a lot with this also, I've heard nurses say to me things like, well, I could feel my patient's pain and things of that nature. That's not really, I mean, it's appropriate to appreciate that someone is in pain, but you don't literally feel someone else's pain. Then there's pharmaceutical optimism. They have this powerful belief that taking a medicine is going to take care of everything. I have had countless nurses say to me that they have chronic back pain and that's how they got on whatever medication they're on. And when I ask them what other strategies they have tried for dealing with their back pain, they haven't tried anything except drugs. They haven't thought to ask about physical therapy, heat, exercise, anything like that. There's also a huge tendency of nurses to self-diagnose and treat their health problems. They'll walk up to a friend of theirs that they work with and say, I've got such and such, write me a prescription for so-and-so. And this is not really appropriate. But nurses have this idea that they know best how to treat themselves, and that is erroneous. Nurses also see themselves as caregivers and caretakers, not care recipients. This means nurses are uncomfortable asking for help. When it is suggested that they may need to take several weeks off to get substance treatment, their initial reaction is one of panic. Then they'll deny they need treatment, they need to keep working, etc. Then there is the general attitude of entitlement. I've heard countless nurses say to me that they are not like those addicts because they don't take street drugs, somehow thinking that addiction to street drugs is different from addiction to prescription drugs. It is not different. It's exactly the same. And a lot of nurses, really, it's a point of pride for them. They don't consider themselves like those people, as they would say. They continue to state that they should be able to continue working, even with substance use disorder. And I've had some tell me that, well, they have a prescription for the drugs, so they're not an addict. There's a lot of arrogance here, too. I'm immune to addiction. They think that because they're a nurse that this is not going to happen to them. There's a little bit of difference between what the drugs of choice are for the general public and drugs of choice for nurses. It is estimated that 22 million Americans abuse substances or alcohol. The most commonly abused drugs for adults that are older than 18 years are alcohol, marijuana, prescription pain relievers, and other illegal drugs. Prescription drug abuse is on the increase in the general public. For nurses in Alabama, by far the most commonly abused drugs are prescription opioid drugs. Next is alcohol. After that is benzodiazepines and sedatives, then marijuana, and then the rest of the drugs are kind of all there together. We do see some amphetamine and stimulant abuse, some cocaine, and some other drugs. Of the opioid and opioid-like drugs, hydrocodone at this point in time is by far the most frequently named drug of choice. Now, this could change because recently hydrocodone was made a Schedule II controlled substance instead of a Schedule III, which somewhat limits its availability. All the other prescription opioids, we see occasional Demerol abuse, a lot of oxycodone, a lot of hydromorphone or Dilaudid, and a reasonable amount of fentanyl. We're also seeing an uptick in the use of heroin because heroin is illegal, but it is very cheap and it is very pure, what is out there now. Other drugs that are abused are opioid-like drugs, and they're listed underneath that heading. Alcohol. A lot of nurses seem to think that because alcohol is legal, the Board of Nursing should not be involved in this. Well, a nurse may not drink on the job, but people who have alcohol problems have no doubt gone to work when they were hungover. We have lots of examples of nurses that drank a whole lot the night before, got up early, went to work, and still had a grossly positive drug screen for alcohol. Long-term use can cause permanent changes in cognition, and it may cause permanent organ damage. Withdrawal from alcohol may be life-threatening. And there's some statistics there about alcohol listed. And the benzodiazepine and sedative group, benzodiazepine with the more immediate onset and shorter duration times are more addicting. The most frequently named benzodiazepine of abuse is generally Xanax. Long-term use can cause significant problems with cognitive function, and withdrawal can be life-threatening. Detox really needs to be done in a supervised setting. A lot of people will realize that they have problems with Xanax or with another benzodiazepine, so they'll decide they're going to go home and do their withdrawal cold turkey. Unfortunately, a lot of times this means that the person has seizures. They end up in the emergency room, and it's a mess. And so they really need to be supervised with their withdrawal. We also see a lot of abuse of Ambien or Zolpidem. This is not a benzodiazepine. It's a sedative hypnotic, but it causes blackouts and significant cognitive deficits if people abuse it. With marijuana, marijuana is one of those things that I have to scratch my head with nurses that continue to use marijuana, because this is one of those drugs that hangs around in your body for a long, long time. Marijuana is lipophilic. It likes fatty tissues, and it gets stored there, and so it's released over time. We have had people who were heavy users that continued to have positive drug screens for marijuana for several weeks. Marijuana positive urine drug screens are not caused by inhaling secondhand smoke. We hear this all the time. Oh, well, I don't smoke, but I was with a bunch of people in a car and they smoked. That doesn't happen. It just doesn't. Now, marijuana is legal in some jurisdictions, but in Alabama it is still illegal. Even if it becomes legal, marijuana will probably be treated like alcohol in the workplace. So think about that. And you can certainly buy marijuana in a jurisdiction where it's legal, but realize that it is illegal here, and it's not going to be a great thing if you have a positive drug screen for it. Amphetamines and stimulants, these are usually prescription drugs. We have a few people who do name methamphetamine as their drug of choice, but we really don't have that much of that with nurses. We see a lot of abuse of Adderall, Vyvanse, diet drugs like Adipex and other things. This slide is here not because barbiturates are a huge drug of abuse with nurses any longer. This is primarily to let you know that it isn't and why. This is rare now. Once the benzodiazepines came on the market, abuse of barbiturates became much less because benzodiazepines are inherently much safer as long as you don't combine them with alcohol or things like that. If we do have someone who's abusing a barbiturate, it is usually butalbital. This is an ingredient found in many headache medications. Occasionally we will see a phenobarbital positive. Nobody really abuses phenobarbital. You don't get high from it. It's an extremely long-acting drug. But this is found in Donatal and different other things that are given, a GI cocktail kinds of things for that. Some other drugs we do see. We see a fair amount of abuse of Soma or carisoprodol. This drug is metabolized to meprobamate, which is an older drug that's a tranquilizer, and it is very, very sedating. This causes severe cognitive deficits, and we see an increasing amount of people taking this. This is a great muscle relaxer, but it's not too good for your cognitive function. We occasionally see abuse of Robaxin and Flexeril. And we do see a reasonable amount of abuse of Benadryl. This is one that's easy for people to steal, and they can buy it over the counter in a capsule form or a pill form. And we do see a fair amount of that. So how do nurses get their drugs? Almost all of the nurses begin their drug use with prescriptions for legitimate health problems. As time goes on, they keep wanting to get the drugs, and gradually a lot of the doctors will say, I'm not comfortable continuing to give you this drug. So they begin to doctor shop. I recently signed someone up in VDAP that had 23 different prescribers and 17 different pharmacies in a 2-year period of time. They may also use the drugs of families or friends. Very often they may get a pill from mama or daddy or somebody, and then they continue to go back and get it, and they don't tell them that they're getting the drugs. They may purchase drugs legally like alcohol. We also see an increasing number of nurses buying street drugs. They can get oxycodone and Xanax and all sorts of stuff on the street. We see a certain amount of internet purchase, but not really as much as you might think. Then there is diversion, and I like to call this what it is. It's called stealing. This very often begins as someone inadvertently keeping a medication that they should have wasted. Maybe they sign out 2 Norco for the patient, and the patient says, I only want 1. So they give the patient 1, and instead of wasting it, they stick it in their pocket, which they shouldn't do anyway, and then they go home, and then, oh, I think I'll take this. Then they may sign out medications that are not given to the patient. They may sign out a whole bunch, not give the patient all of that, give them an appropriate amount, but then take the rest of it for themselves. They may sign out more medication than is ordered. They may give some to the patient, take the remainder. Things like they sign out 4 milligrams of morphine, they give the patient 2, they keep 2, and they go home and play. Or they go in the bathroom, whatever. Or there's tampering. Tampering implies intent. It's when you substitute something for the medication. If the narcotic or the controlled substance is a round white pill, they may find another round white pill to put in that package. Or they may take out the injectable drug and replace the morphine with normal saline. If the tampering is widespread and on a large scale, this may involve the FDA in an investigation. And there's always obtaining controlled substances by fraudulent means. They may forge a prescription, they may alter a prescription written for them, they may call in unauthorized prescriptions, or they may order medications through a patient portal or something of that nature. All of these involve using a prescriber's DEA number, and this is all fraudulent. They are trying to get drugs. They do not have appropriate prescriptions for them. There are different charges that may be brought if somebody gets arrested. They may be arrested for possession of a forged instrument, for example, for forging a prescription or changing it. Possession of unauthorized controlled substances if they go and pick the medication up, that sort of thing. Now, a word about terminology. The term impaired nurse is being phased out somewhat because most nurses with substance use disorder do not have signs of impaired practice. They may certainly be working acutely under the influence, just as someone who gets a DUI is under the influence but may not be an alcoholic. However, if they're caught under the influence, you have to deal with that, obviously. But most nurses who have an addiction diagnosis or a substance use disorder diagnosis, this does not automatically equate with impaired practice. And please keep in mind that workplace signs of substance use disorder are late signs. It's usually after the addiction is well established. The next few slides are going to go over some behaviors that you may see with people who have substance use disorder, or you may not see them. They may have these behaviors for other reasons. Absenteeism and tardiness, mood swings, changes in personality or demeanor. They may isolate themselves from coworkers, and they may be sleepy on the job. There may be changes in their work habits. They may fail to follow through. They may not have the appropriate attention to detail. They may be absent from the work area for unknown reasons. They may come to work on days off, or you may see changes in their grooming. Now, some or all of these behaviors may signify a problem with substances, but they may also be due to any number of things that can happen. Somebody may have a new baby. They may not be getting much sleep. They may be having problems in their marriage. There may be the illness of a family member. There may be lots of things going on where these things could happen. This is where it is important for a supervisor to know their employees. Now, related to controlled substances, there are some things that you may see. One is withdrawals without corresponding entries on the medication administration record. There may be a lot of wastage or breakage for this person, or there may be no witnesses for the waste. The nurse may volunteer to give medications. Or I love this one, they may sign out all the controlled substances for the shift at the beginning of the shift. Last time I checked, we weren't supposed to do that. They may give medications to patients not assigned to them or that aren't on the unit. I've seen lots of records where someone has actually been transferred out of the unit and to another place in the hospital, or they've gone home or something, and there are medications that are signed out to them. There may be an increased frequency of sign-outs compared to other staff members. Or they may sign out several controlled substances at the same time for the same patient. Most patients in a hospital may have one kind of medication for severe pain, say morphine, another for moderate pain, say a Norco or something like that. And what you'll see is that they may sign out both of them at the same time, which last time I checked, we really weren't supposed to do that either. So here we come to things where it might be helpful for you to safeguard your controlled substance inventory and to detect problems. First of all, what are your policies and procedures about controlled substances? Are there routine pharmacy audits for this? Do you, as the supervisor, check the controlled substances frequently? Are you a known presence? If people are given medications, are you around? Do they see you? Do they see that you're watching? The single most powerful deterrent can be a supervisor who knows what is being given and who audits things and who assists others in giving medications. Also, is it a standard practice in your facility to borrow medications from one patient for another because that patient's medications are not available yet? If so, this is a problem in your system that you have to address, because when people get admitted or they come in for something, then their medications need to be available for them. What are your inventory control systems? Do you have a computerized system? And if so, do people change their passwords as regularly as they should? Do you audit it? Are you looking at charts to see that what is signed out is actually charted? Things of that nature. Are the staff using the safeguards built into the system, or are they bypassing them? And the answer to that question is not really that important. If they are bypassing the system, the important answer is to find out why they are bypassing it, because many systems are designed not with the end user in mind. And when nurses are having to do a lot of things that are repetitive and difficult to do, then it's easy to begin to bypass them. Also, with drug screens, does your facility or does your employment situation have the ability to do for-cause or reasonable suspicion drug screens? Urine specimens are the easiest, and they're the least costly overall. Now, a lot of policies for drug screening are set at the corporate level, and that's fine, but any facility or any employer that deals with controlled substances needs to have policies that allow for this kind of testing and that they're testing for the appropriate drugs. Urine specimens are accepted as evidence in court cases as long as there is an intact chain of custody trail. You also need to have confirmation of any positive results. Now, testing for substances is expensive. A basic drug screen here at the board for nurses we monitor is about $50, but it can be up to about $100. And we test for a lot of things. It's not always realistic for you all to be able to test for all of those things with a chain of custody specimen for every specimen, but you should be able to do that for anything that comes back for that has a screening positive, and I'll explain that a little bit. Okay. Many workplaces do something called point of collection tests, or POCT. These are the kind that are instant read. Somebody gives you the specimen, you dip the thing in, and it gives you a result of some sort. Okay, these are notorious for false positives and for things that are, maybe not exactly what they appear to be. So you have to have some kind of follow-up on those specimens. You need to do a chain of custody specimen that is then sent for appropriate confirmation testing. Also, many workplaces have drug screens that do not include the most appropriate drugs for health workers. I can remember several years ago talking to someone about a drug screen on someone, and the drug that in question was hydrocodone. And I said, well, did your drug screen test for that? And initially she said, well, of course it did. I said, well, check. And it turned out it didn't. It only tested for the naturally occurring opiates, which are morphine and codeine and heroin and things of that nature. So if you're going to do drug testing on healthcare professionals, you've got to have the healthcare professionals' opiates included in there. Also, we see a lot of employment decisions made on the basis of a point of collection test with no confirmation of the result. That is not fair to the employee, because you can see all sorts of things show up positive on those point of collection tests, but unless it is confirmed, that's not going to stand up anywhere. In general, the board does not discipline a nurse's license if the drug screen sent to us is not collected as a chain of custody specimen, if positive results do not have GCMS confirmation testing, and the positive results are not reviewed by a medical review officer. GCMS confirmation testing is a combination of a couple of techniques. Basically, if you have a positive screen that's a screening test, like a point of collection, you just know it says there's something there. The GCMS confirmation tells you exactly what's there and in what concentration. Then this should go to a medical review officer, who then should talk to the person on whom the test was done and find out, do they have prescriptions for these things, and to get any kind of verification needed. We're not going to discipline a nurse that's the only evidence that we have is a drug screen that's not chain of custody and doesn't have confirmation testing or a medical review officer. So what is the role of the Board of Nursing in dealing with nurses with substance use disorder? First of all, the Board of Nursing is required by statute to protect the public welfare by ensuring that nurses meet minimum standards for education and safety. We do this in 4 ways. The first way is regulation of basic nursing education programs. The second is regulating who enters practice here, either by exam or endorsement. The third way is through biannual renewal with appropriate continuing education. And the fourth way is through discipline of license and or removal of a nurse from practice. A nursing license means that you accept responsibility for your own practice and for the practice of others. You need to report illegal, substandard, unethical, unsafe, or incompetent nursing practice. The Board of Nursing in Alabama believes it is in the best interest of the public to monitor nurses who are returning to the workplace after treatment for substance use disorder. This means alcohol, opiates, cocaine, you name it. This slide is a simplified version of our disciplinary processes and what happens when someone has a complaint open, and it shows that how we try to determine VDAP eligibility. Once a complaint or a self-report is received, if it has anything to do with a substance problem or something about substances, then it should be routed to determine VDAP eligibility. If the person is eligible, then they are referred for evaluation and treatment. Once they complete all of their recommended treatment, they sign their VDAP agreement and they're monitored. If someone is not eligible for VDAP, they go through the investigation process. Then one of the nurse consultants reviews that and they determine what kind of discipline needs to be done. And if they sign a consent order or have a board order, then they are monitored. If there's insufficient evidence for the case, for any discipline to be done, then the case is closed. The complaint process. A complaint can be submitted by anyone. We have an online form that employers or consumers can use. We will accept anonymous reports, or the nurse may self-report. The only person who can actually report themselves by telephone is the nurse themselves. Someone can't telephone me and say, so-and-so has a problem, I want you to do something about it. They have to do that in writing. Then the nurse is evaluated for VDAP. What is VDAP? This is the Voluntary Disciplinary Alternative Program. Alabama has had an alternative to discipline program since 1994. This is not disciplinary action. Nurses must meet the eligibility criteria for the program and admit to having a problem and request participation in the program. Their licensure status is active. Nurses who want to enter VDAP do not have a suspended license at any time. The legislation and the rules that govern VDAP are found on the board's website. The Nurse Practice Act, the part that contains this information, is Article 2 in licenses. In the Administrative Code, it is Chapter 610-X-13. To find these things, you go to our website and you look there where it says laws. Now, the content in the Nurse Practice Act and the Administrative Code sections are updated whenever there are changes. The Nurse Practice Act is the actual enacting legislation that was passed by the Alabama legislature. It outlines the intentions of the legislature, but it doesn't give the procedures or any of the ways that this is put into effect. This information is covered in the Administrative Code. Now, the Nurse Practice Act can only be amended by the legislature, whereas the Administrative Code and the rules are amended all the time by the Board of Nursing. When you click on the laws, it will have either the Nurse Practice Act or the Administrative Code, and you click on whichever one you want to look at. If you look at the Nurse Practice Act, this is what you will see. And again, it's Article 2 that has the information about licensure, discipline, and VDAP. If you look at the Administrative Code, the VDAP chapter is the very last one. Now, who's eligible for VDAP? First, the nurse has to admit having a problem and request participation. The nurse either has to have an active license or be eligible for an active license in Alabama. There cannot be any previous disciplinary action for any reason in any jurisdiction. This means if somebody had discipline because of a CE violation or because of an unprofessional conduct violation, even if it was just a reprimand and a fine, they are not eligible for VDAP. If there are previous felony convictions or the person has pending felony charges, they are not eligible. Most drug-related charges are felonies. Now, paraphernalia is not, but possession of controlled substances is a felony charge. Then the nurse has to cease practice immediately. One of the objectives of establishing an alternative to discipline program was to get nurses who needed help out of practice sooner. The disciplinary process can be very long, and very often people really should get out of practice sooner than they do with discipline. But if they want to be in VDAP, they have to cease nursing practice. And the nurse has to cooperate. If we tell them where they need to go for an evaluation, and we usually give them at least 2 choices, then we expect them to go. They have to go as soon as they can. Generally, I tell them within a month, if they can. Sometimes the treatment providers are backed up and they can't get people in within that month. And they have to complete all the treatment recommendations, whether they like them or not. VDAP is built on trust and cooperation. Because the nurse is not publicly identified, their licensure status is not publicly identified as someone who is monitored, they must do what they are told regarding working, evaluation, and treatment. The nurse has to sign releases so treatment providers can communicate with us. They may not return to nursing practice until we have from the treatment provider written documentation that they're safe to return to practice and they have signed their agreement for monitoring. And this is kind of a repeat, but you know, it's included in eligibility criteria, but we also put it in denial for VDAP, disciplinary action for any reason, pending felony charges for any reason. It could be theft of property second or something like that. Also, sometimes board staff determine the nurse is not going to benefit from the program. We no longer allow people who have completed the Alternative to Discipline program twice to enter it again. Since we've had the program for over 20 years, then it's important. We do get some people who repeat, and one repeat is generally okay, but if they come back the third time, they're going to go to discipline. Or if the nurse is just plain old uncooperative. I've had people who, yes, I want to be in the program, yes, I want to be in the program, yet they would never do what they were told to do. And so after a while, I'm just not going to play anymore, and we send them to discipline. Okay, if people go through discipline, what does that mean? Well, first of all, they go through investigation. They have a special investigator assigned. Subpoenas are sent out. They review records, and some of the records that they may review are licensure records, criminal charges, criminal records, patient records, controlled substances records, employment records, pharmacy profiles, and the like. Once the investigation is complete, it's reviewed by a nurse consultant and determination of the violations of the Practice Act and the rules are made, and the type of discipline needed is determined. Most of our cases here are settled informally by consent order. We have guidelines that the board has passed that we can settle these cases without people having to go to hearings, which is extremely expensive and time-consuming, as long as the guidelines are used. If someone is in discipline but they've admitted they have a problem, they've gone to treatment, etc., there's not quite as much investigation that is needed because we have the records from the treatment provider, and we can usually settle that case a little bit more quickly. If the nurse accepts the consent order that they are offered and signs it, then the consent order is placed on the agenda of the next board meeting where discipline is considered and voted upon. The order then goes into effect after it's accepted by the board and service to the nurse has been attempted. The Board of Nursing meets every month in Montgomery, but the months listed on this slide are the months where discipline is considered and voted on. The next couple of slides will compare VDAP and probation monitoring because there's a lot of confusion about that. First of all, VDAP is a front-end action. VDAP eligibility should be determined very soon after that complaint is received. It shouldn't be open at the Board of Nursing for several months and not have some kind of consideration about that. Probation, on the other hand, is kind of a back-end thing. It happens after the disciplinary action. Most of the consent orders for people who have substance use disorders are consent orders that suspend the license until the appropriate treatment is completed. Then, once the suspension is lifted, they go to probation monitoring. VDAP carries a $1,000 monitoring fee. And keep in mind, we're only talking about full-length VDAP substance use disorder agreements and full-length probation substance use disorder orders. With probation, there is a maximum $1,000 fine per violation. So the amount of money someone in probation might need to pay may be higher than the $1,000 fee for VDAP. A VDAP agreement goes into effect the day it is signed by the nurse. So when they come down here and sign an agreement for VDAP, that agreement is effective that very day. Whereas with probation and the orders for discipline, they go into effect after the order is accepted by the board and also the nurse, there's notice that the nurse has been served with it, that it's been delivered to them. The monitoring provisions in both of these kinds of monitoring are basically the same. In VDAP, we only monitor issues that are related to substance use disorders, mental disorders, or physical illness. Monitoring and probation may occur for all other kinds of orders, including any kind of practice-type violations. With VDAP, there is no report that is sent to the National Practitioner Data Bank or from there to the Office of the Inspector General. Whereas with probation, all discipline is reported to the National Practitioner Data Bank, and it may get reported to the Office of the Inspector General. The licensure status of VDAP nurses is always active. It does not say suspended, active/monitored. It doesn't say any of that. It simply says active. Whereas the licensure status for people who have had discipline may be suspension or active/probation. VDAP agreements are not public record. However, orders for probation, for discipline, are always a matter of public record. The monitoring requirements for full-length agreements or orders for substance use disorders are 5 years. with options to complete in 3 years for most of the first-time orders and agreements. Aftercare and continuing care is required, a minimum of a year, once-a-week meetings. It may be longer depending on what the treatment provider requires. Counseling is almost always required. The length of time and the frequency is determined by the treatment provider and the counselor. All the nurses have to go to abstinence-oriented support group meetings, a minimum of 3 meetings per week for the duration of monitoring, and they have to have a sponsor. This can be AA or NA meetings. It could be Celebrate Recovery. It could be any number of things. They are also required to do random drug screens for the duration of monitoring. Their frequency is random, but it can be 1 to 5 times per month. The cost of the urine drug screens ranges from $50 to $100 for each drug screen. If they do any hair testing for us, that can be greater than $200 cost. If we do some other kinds of alcohol testing, that may be $100 to $130 or so. They must also identify their health care providers, a primary provider, any specialty providers, and they have to have prescription verification for all prescription medications and many over-the-counter drugs. They need to use one pharmacy. For practice restrictions, a full-length agreement or order, they have to work a minimum of 24 months in a job that requires the appropriate nursing license for an average of 96 hours per month. Okay, the appropriate nursing license, that means an RN cannot take a job that is an LPN job. If it requires an LPN license, an RN doesn't have that license. It must require an RN license or an LPN license, whichever kind of license the nurse has. For probation monitoring, you need to make sure you check the order carefully regarding the required time to be worked in practice, because it may vary. Also, all advanced practice nurses are required to work 1 year as an RN. This is in the VDAP rules, and I believe it's in the discipline rules also. The nurse has to have a monitor. Now, this may be the supervisor, and if the supervisor and the nurse work the very same hours, that's cool. But if the supervisor and the nurse do not always work the same hours, you're going to have at least one other monitor who is in the house, who is physically present in the facility where the nurse works while the nurse is on duty. They cannot work alone or in any environment where they are expected to function independently, and we've listed several of those areas. We don't allow them to be supervising nurses. After they've been monitored and working for about 2 years, if you want them to be a charge nurse occasionally or something, we can usually work that out. But in general, their position cannot be one that is administrative. The hours worked can be no more than 84 hours in a 2-week pay period. Call time may be fine, but it needs to be discussed with the board staff before the nurse begins taking call. Most of the nurses will have restricted access to controlled substances for a minimum of 6 months of employment. However, some nurses don't have the restrictions, so you need to read the order or the agreement closely. The restriction begins when the nurse returns to a job that requires their particular nursing license. This is another one of those terminology things. This is a controlled substances restriction and not a narcotic restriction, because there are many more substances that are controlled drugs than narcotics. Narcotics are specifically opioid and opioid-like drugs, and there are lots of other things people abuse and sign out in a hospital setting or in any other kind of setting, whether it's a nursing home or skilled care or whatever. And many other substances are abused and diverted. I list all of these things here because we get confusion about things. Basically, we don't want the nurse having anything to do with controlled substances. They don't administer it, they don't witness it, they don't document, they don't do any of that. If they're working in office settings, they can't phone in orders, pick up controlled substances, they can't order things through a patient portal. They don't need to have anything to do with controlled substances in the workplace. Now, what are the responsibilities of a monitored nurse in coming back to work? The agreement and the orders, they don't require them to tell you about this before coming to work. But we always tell them that they need to discuss this when they interview, before an employment offer is made. The agreement actually says that within 10 days of their employment, the supervisor, the employing agency, needs to notify us of their employment and your receipt of the agreement, etc. I tell them if you don't find out about the monitoring until they hand you that agreement after they've started work, that they probably won't work for you very long. They also need to provide you with the entire order and agreement, not just the parts they want to give you. The pages are now numbered, so if you see that you get pages 5, 6, and 7, that's not correct. You need to have the whole thing, and usually our agreements are somewhere between 12 and 14 pages long. They also need to discuss the order and agreement with you as a supervisor in detail. This shouldn't just be them coming in and saying, here, let me give you this. You all should probably sit down and have a real conversation about this and go over the restrictions at that point in time. They also need to notify us of any changes in their employment. They also need to be honest with you in all interactions. And they need to make only reasonable requests of you. For example, they're going to have to do drug screens. And if they're working a 12-hour day shift, they're going to have to leave sometime during the day. And that needs to be accommodated because they're going to get in trouble if they miss the drug screen. And you drug screening them there doesn't substitute for our drug screens. Also, they have to go to aftercare continuing care meetings. These are not held at an endless variety of times. There's usually only 1 or 2 times that they can go, and they're supposed to go to the same meeting every week. This needs to be accommodated. Now, you don't need to accommodate requests about any of their support group meetings because those are held much more frequently, and they generally have many more choices about that. They also need to remind you about the quarterly reports that need to be sent. Now, the employer responsibilities. You need to complete the notification of receipt of the order or agreement when the nurse is employed. They're supposed to hand you that form, hand you the agreement, and any handouts they've been provided about employment. You need to read those. There are so many times that I get calls from supervisors or employers who just haven't read the agreement. And if they had read the information, then they would already know the answer to the question. Another thing is to contact the board staff member that's identified for you if you have any questions about any of the information. I don't mind talking to people, and I know that my counterpart in probation doesn't either. You need to choose an appropriate supervisor or monitor for the nurse. If you, as the supervisor, are not going to be working when the nurse works, you've got to choose other people. It's nice if it's one other person, but we live in the real world. I had a nurse several years ago that worked at a long-term care facility, and I believe every licensed person in the facility functioned as her monitor, and that was fine. Everybody knew the score. Please submit the reports to the Board of Nursing on time. All of our reports are online. We do try to send out reminder emails, but because these are sent to a very large number of people, your computer system may not allow that particular email through. So we provide you with things that tell you when these reports are due. So please keep track of that, and the nurse should remind you too. You also need to inform your board contact if there are any problems with the nurse. Any issues that required any kind of conference or whatever. This doesn't mean the nurse is going to get in trouble with us, but it's important for us to know what's going on. I can't tell you the number of times that I have gotten reports on a nurse that the nurse is wonderful, doing everything they're supposed to do, etc., and then I get a notice that the nurse has been terminated because they had had too many write-ups and conferences for problems, and I didn't know anything about it. This isn't good. I really need to know, even if, I may not do anything with it, but I need to know. You need to notify us if the supervisor or the monitor changes. The nurse needs to get another one of those forms and have that for the new supervisor to send it in, because if we don't have the appropriate name and email address, then that new supervisor won't be able to submit the reports. Please report the actual time the nurse works and the reports. And if the nurse has a controlled substances restriction, you should receive some documents from us, and we will request some things from you, like time reports, and please get them back to us in a timely manner, because the sooner we get all the information back, then the sooner we can finish the review and lift the restriction. We also would ask that you honor reasonable requests for accommodation. Reasonable requests are, I have to drug screen. I need to leave 30 minutes early because I need to go to aftercare. Outside of those things, I don't think there's any request that's particularly reasonable. What about supervision? Especially in the beginning, the supervisor and the monitor need to have frequent contact with the nurse. Talk about what's going on, is it going okay, etc. You need to be vigilant but not paranoid. You should drug screen this monitored nurse as you would any other employee according to your facility's policies. You do not have to drug screen them every time anything happens. It's appropriate to drug screen them if they're on the unit when there's a discrepancy, but if they're at home on a shift, when there's a discrepancy, I'm not sure that they need to be drug screened. So do this when it's appropriate. Ideally, you should have a partnership with the monitored nurse and the supervisor and the monitors. It should not be an adversarial experience. And hopefully, as time goes on and the nurse is more comfortable, then his or her monitoring can be a learning experience for everybody else. I hope that this presentation is helpful to you in monitoring nurses that have substance use disorder. My contact information is here. And the next slide has the contact information for the probation monitor. The last two slides in this presentation have references that were used for this presentation.